Welcome back to the deep dive. If you're prepping for the MSRA SJT, you know it's not just about the medicine, is it? It's often about juggling. Well, everything at once.
Exactly. And today we're tackling a classic high-stakes situation. Clinical prioritization under pressure. The competing bleep scenario everyone dreads but needs to master.
Yeah, it really tests your ability to think clearly when things are hitting the fan, so this is a priority question. Remember, that means you'll see 8 options, and your job is to pick the 3 most appropriate actions.
That's the task. It's about immediate safety and professional conduct, pulling on those core GMC principles.
Absolutely.
Okay.
So, maybe grab a pen and paper if you haven't already. Let's dive into this evening shift scenario.
Okay, picture this. You're the medical SHO. It's early evening, you're covering 2 wards, and suddenly, bang, 5 things land on you all at the same time.
Right, first up, the big one. A nurse calls you 72-year-old patient, known pneumonia. Now they're acutely short of breath. SATs are 82% on air.
Wow, okay, 82% on air. That's an immediate emergency alarm bell right there.
Definitely. Then, almost simultaneously, the ED rings. They need TTAs, the discharge summaries, for a stable patient. And they say they need them, in 30 minutes because of patient flow pressures.
The classic admin squeeze. Always feels urgent, doesn't it?
It does. Third thing, radiology phones. It's about a routine outpatient ultrasound result query. Seems pretty non-urgent compared to the others.
Okay.
Fourth.
Your FY1 flags you down. They need you to check a warfarin dose before 6 p.m. They're not sure about it.
Right, a prescribing check. Important, but is it immediately life-threatening? We'll see.
And finally, number 5. Switchboard patches through a call. It's a relative wanting an update on a patient.
Okay, so a real mix there. A clear emergency, admin pressure, routine stuff, a junior needing help, and communication. Now, the context is also key, isn't it?
Yes, absolutely.
Yeah.
You're told the nurse in charge can help you out with some things. Your medical registrar is contactable, though busy. And crucially, the ALS team, or the 2222 emergency number, is available. All right, so you're not completely alone, but you are the one making the initial decisions. The task, again, pick the 3 most appropriate actions to take right now.
Okay, let's run through the options. Think carefully what has to happen immediately.
Option 1, go immediately to assess the hypoxic patient, start an ABCDE assessment, give oxygen according to protocol, and ask for OBS and a VBG.
Option 2, call 2222 ALS or the medical registrar for urgent support while you're on your way to the hypoxic patient, giving a concise SBI handover.
Option 3, ask the nurse in charge to pause or redirect your non-urgent bleeps, let E know the TTAs will be delayed, and document that you've reprioritized.
Option 4, prioritize writing the ED discharge TTAs first because, patient flow targets have to be met.
Option 5, tell the FY1 just to hold the warfarin dose for now and you'll review it later, but you don't actually assess the patient yourself first.
Option 6, end the call with radiology by telling them to ask the GP instead because it's not urgent for you right now.
Option 7, ask the ward clerk to take the relative's details, reassure them someone will call back later, and make sure the team does consent and ID checks before any info is given.
And finally, option 8, advise the nurse looking after the hypoxic patient to only escalate to outreach or critical care if the patient actually arrests.
Okay. 8 options. Which 3 are the absolute must-dos?
Take a moment now. Really think about that patient with 82% SATs. What needs to happen now for safety and good practice? We'll pause for a second.
Hard silence.
All right, let's see how you did. What are the top 3 actions here?
The 3 best options, the ones that cover immediate safety and professional responsibility, are 1, 2, and 3.
Okay, 1, 2, and 3. So that's immediate assessment, immediate escalation, and immediately getting control of the other tasks. Let's unpack why these 3 work together, starting with number 1.
Well, action 1 is non-negotiable, isn't it? You have a patient who is critically hypoxic.
Yes.
SpO₂'s 82% on air is, frankly, terrifying. Patient safety is always paramount. That's GMC 101. So you have to go immediately. And what do you do when you get there? You start the ABCDE approach. That's the standard for any acutely unwell patient. Getting oxygen on, getting baseline OBS, thinking about a gas.
Yeah.
That's step 1 in stabilizing.
Makes total sense. You have to deal with the immediate life threat first, but then action 2, calling for help while en route. I asked this before, but isn't there a risk that fiddling with your phone delays you getting to the bedside? Shouldn't you get there, assess, then call?
It's a really good question because it feels counterintuitive sometimes. But think about it. Severe hypoxia like this suggests the patient might deteriorate very rapidly. They might need interventions you can't provide alone, like intubation.
Okay.
Calling 2222 or your reg as you're moving means the cavalry is alerted sooner. Those couple of minutes you save by initiating the call early could be absolutely crucial for getting advanced help to the patient faster. It's about concurrent activity in an emergency.
I see. So it's not delaying the assessment, it's speeding up the definitive response. And the SBR part. Why is that specifically mentioned?
Because in a crisis, communication needs to be crystal clear and efficient. SBR situation, background assessment recommendation gives you that structure.
Right.
When you call the reg or hand over to the crash team, you can quickly say, situation, 72 yo, hypoxic, SATs 82%. Background, no pneumonia. Assessment, acutely short of breath, I'm on my way. Recommendation, requesting urgent review, ALS attendance. No waffle, just the critical facts. It's safe, professional communication under pressure.
Got it. Okay, so we're assessing and escalating simultaneously. Now, action 3. Asking the nurse in charge to manage other bleeps, telling EB about the delay, documenting. Why is this administrative management part of the top 3 immediate actions?
Because if you don't do this, the chaos continues. Those non-urgent bleeps, the radiology query, maybe even the relative call initially, will keep interrupting you while you're trying to manage a critically ill patient.
Right. You need focus.
Exactly. You need to insulate yourself and the immediate situation. Asking the nurse in charge to intercept non-urgent calls is sensible delegation. Critically, though, you must communicate the delay, especially to ED regarding the TTAs. Just ignoring them is unprofessional and unsafe for patient flow down the line. And documenting your decision to reprioritize is vital for accountability. It shows you made a conscious, justifiable decision based on clinical need. It protects you, the patient, and informs the team. It's about managing the system safely, not just the patient in front of you.
That makes sense. It's proactive control rather than reactive firefighting. So that's why 1, 2, and 3 are the priorities. Let's quickly look at why the others are wrong or less appropriate. Option 4, doing the TTAs first.
That's a huge red flag, isn't it? Prioritizing administrative targets like patient flow over a patient with life-threatening hypoxia. That fundamentally breaches your duty of care. It's dangerous and absolutely incorrect.
Another question. Okay, option 8, telling the nurse to only escalate if the patient arrests.
Also incredibly dangerous. Escalation for hypoxia needs to be preemptive, based on the deterioration, not waiting for a catastrophic event like an arrest. That goes against all guidelines on recognizing and responding to the acutely ill patient. Definitely incorrect.
Right. Now, option 5, telling the FY1 to just hold the warfarin without seeing the patient or knowing why the FY1 is asking. You flag this as unsafe. Why exactly?
Because holding a dose is a prescribing decision. Making that decision without any clinical context. Why is the FY1 unsure? What's the patient's INR? What's their bleeding and clotting risk? Is unsafe. You're essentially giving remote advice without assessment. What if the reason the FY1 was worried was valid and holding the dose causes a clot? Or what if holding it was wrong and they needed it? You haven't properly supervised your junior or taken responsibility for that clinical decision. It's an unsafe shortcut.
So it's not just about the warfarin itself, it's about the lack of assessment and supervision.
Precisely. You need more information before making or advising on that decision, even if it seems minor compared to the hypoxic patient. That task needs safe deferral and proper review later. Okay. And the last 2, 6 and 7, the radiology call and the relative.
Well, action 7, asking the ward clerk to manage the relative's call, is actually good practice in itself. It delegates appropriately, ensures a callback, mentions consentity checks. It's the right thing to do with that call, eventually. But it's not one of the top 3 priorities when someone's SATs are 82%. It can be safely deferred.
So appropriate but not immediate priority. And action 6, being abrupt with radiology.
That's just poor professionalism, isn't it? While the query isn't urgent for you right now, telling a colleague to basically go away and ask the GP is disrespectful. Option 3 covers this better politely deferring non-urgent tasks via the nurse in charge, or handling it yourself briefly once the immediate crisis allows. So action 6 is less appropriate because of the unprofessional manner.
Right, that makes the ranking clear. So distilling this down, what are the key takeaways for listeners facing these prioritization questions? Okay, 3 main things, I think. First, patient safety trumps everything. That SpO error of 82% dictates your immediate action. Always go back to the ABCDE approach. That's non-negotiable.
Got it. ABCD first.
Second, escalate early and effectively. Don't wait for things to get worse. Use your team, the reg, the crash team, via 2222 ALS. And use structured communication like SBR when you do. It's about teamwork and recognizing your limits.
Okay, early escalation.
And third, manage the chaos safely. You have to deal with the non-urgent stuff, but do it by safe deferral. That means communicating the delay to those affected and documenting your decision to reprioritize. That shows accountability.
So assess, escalate, and control the environment. That seems like a solid framework.
You can almost think of it like triage, but extended. Treat the sickest first, action 1. Raise help early, action 2. Insulate from non-urgent tasks, action 3 via delegation communication. Acknowledge delays and document clearly.
That's a great way to remember it. Keep practicing these types of questions, everyone. Getting that muscle memory for prioritization is key for the SJT.
Definitely. And keep those GMC principles, patient safety, working with colleagues, communication, record keeping at the front of your mind. You've got this.
Before we finish, just a quick thought to leave you with. Going back to that warfarin query, option 5. If you had to give some initial advice remotely in that situation, which we've established is risky, what absolute bare minimum questions would you need to ask the FY1 first, just to cover yourself even slightly? Something to ponder about remote decision-making under pressure.
Good point. We'll catch you on the next deep dive.